Start. Anne, welcome.
Thank you.
Yeah. So we are starting our first Google Hangout to discuss the early identification of recurrent mood disorders in youth. Thank you all for your patience in helping us get this first Google Hangout started. I'd like to introduce the people who will be joining us. Anne Duffy, who's here. She's the, do you say CAPE? The CAPE Professorship of Mental Health.
It's an acronym for Campus Alberta Innovates program, which is a provincially funded program, and there's a lot of resources at the University of Calgary that are being invested in mental health and youth mental health. So, well,
that's terrific, and she's also a professor in the Department of Psychiatry at the University of Calgary, and also from Calgary is Scott Patton, who's in both the Departments of Community Health Sciences and Psychiatry at the University of Calgary. We're also joined by David Coghill, who's a senior lecturer in adult and adolescent psychiatry in Scotland at the University of Dundee.
Actually a professor since 3 days ago.
Well, congratulations.
Thank you.
Congratulations, Dave.
That's wonderful news. That's terrific. Argyris Stringaris is clinical senior lecturer in bipolar disorder and the director of the Mood and Development Lab at King's College London. Who else do we have? Who else do we have with us?
Guy Goodwin.
Oh, Guy, welcome. So, Guy, of course, is the past chair of psychiatry at the University of Oxford and the W.A. Handley Professor of Psychiatry. Guy, welcome, and I'm so glad you were able to make it through the technological haze here. But why don't we start? So Anne Duffy, Professor Duffy, will be reviewing her paper on the early identification of recurrent mood disorders in youth. Anne, if you would like to start,
Sure.
Why don't you review some of the main points, and then we can get into questions, and hopefully we'll have a lively discussion.
Right. Okay, well, thank you very much. Thank you, everybody, for your interest and for joining, and for all of our listeners. This is an increasingly important topic in psychiatry in general, I think, and certainly in medicine. And the topic centers around the concept that we're becoming increasingly aware that major psychiatric disorders, aside from developmental disorders, major psychiatric disorders really onset in adolescence and young adulthood. And yet, sadly, the evidence suggests that it takes us over a decade once an individual has sought treatment to accurately diagnose particularly recurrent mood disorders such as bipolar disorder. And actually, when you look at outcome data, whether you're looking at various disability or mortality data, we haven't actually improved the outcome for people who suffer from these disorders, and particularly bipolar disorder. Now, it's likely, we're becoming increasingly aware that it is likely that there are recognizable changes that are occurring at several levels, certainly clinically, also psychologically, it appears, and certainly most likely biologically. So these changes are occurring years before the full-blown illness manifests. So not only are we missing the boat in terms of patients presenting with serious psychiatric disorders such as bipolar disorder and having trouble identifying that correctly, but we actually could be starting diagnoses much earlier. The obstacles, and I should say the reason that early identification is a major priority is because I think we would all agree that we're becoming increasingly aware that these disorders very early in the course are already associated with substantial disability and early death. And one of the major causes of early death in this population is suicide. And suicide is actually, shockingly, the second leading cause of death in young people in both the United Kingdom and in Canada. So that's quite a major challenge and priority that we have to do a better job of diagnosing these serious illnesses earlier on. Now, what are the obstacles? So that's sort of the preface of this paper, and the obstacles that I raise are numerous. One is the fact that historically psychiatric diagnosis has always been based on what we would call in the rest of medicine end-stage disorder. So we talk about full-blown illness. And if you think about other areas of medicine, and certainly Patrick McGorry and others in the field of early psychosis have been talking about this for a long time, we actually look at early indicators of illness onset and progression. And in psychiatry, we really haven't done that. And the other thing is that we're increasingly aware that our approach to psychiatric diagnoses is based on sort of broad syndromes. And we really have a difficult time understanding trajectories into illness. And this is what I'm challenging in this paper based on the evidence that would really probably move us along, not only in the realm of identifying patients at risk for psychosis or young people at risk for psychosis, but similarly young people at risk for recurrent and continuing mood disorders. Now, then it gets into more of the research that I and others have been developing to shore up this argument about a developmental approach to diagnoses. And essentially, just very briefly, my own work started just over 20 years ago when I was completing my residency training or specialty training in psychiatry, and I had the good fortune to be involved with a very productive research group that were trying to find the genes for the genetic culprits for bipolar disorder. And bipolar disorder, like many major psychiatric disorders, has a genetic basis. And how do we know this? We know this because the most robust risk factor determining who's going to develop bipolar disorder is a positive family history. Now, obviously, families share more than their genes. They share their environment and their exposures, but other studies, such as twin studies and adoption studies, have identified that there is a strong genetic contribution to the risk of developing recurrent melancholic depression and bipolar disorder. However, genetic studies have had a very difficult time because we've become increasingly aware that it's not just inheriting a particular form of a gene or genes, it's multiple genes and probably other mechanisms such as our exposures which change our genetic activity, and these are called epigenetic mechanisms. So it's a much more complicated story, but my good fortune was that I realized that as we were interviewing these families where there was this high risk of mood disorders segregating through the families, we should possibly be paying more attention to the younger generation because we were only interviewing adults. And my question was, well, what is the natural history of these illnesses, and could we study these children who are at specific genetic risk and learn something about the early natural history that could help us and clue us in to the trajectory into these disorders earlier. And that the initial study started 20 years ago, and if there's anyone listening from our research cohorts, I'd like to sincerely thank you for your absolute major commitment to this research. It's been over 20 years. We've all grown older together, and now we're into our next generation of the children having children. So it's been an amazingly informative study. And what we've learned from this study is that, in fact, there are, just even at the basic clinical level, there are recognizable clinical sequences or stages, if you will, that seem to be indicative of those young people who are going to go on to develop recurrent mood disorders such as recurrent depression and bipolar disorder, which are actually related in these families. And so, for example, we were able to show that anxiety and what we call sleep disturbances or circadian disturbances in these kids that confirm genetic risk indicate a much higher risk later in development for developing mood disorders. And so what I've done is proposed a staging model. Now, in parallel, there's been other groups around the world who have been doing very similar research and quite thankfully have come up with similar findings. So there's a large high-risk cohort in the Netherlands, and there's also a large high-risk cohort in the United States, led by Eglin and Shaw. In the Netherlands was Katrien Reichardt and Marjolijn Walls, and now Manon Hillingers. And so there's people who have been studying using a similar design and coming up with these same findings. Now, at the same time, in parallel, there's been people who realize the importance of understanding the natural history of illness, because the implications are we now have new targets. We understand clinically how things are evolving, or the trajectories. So we could, for example, look for earlier opportunities to intervene and prevent the onset or stop the progression of illness using possibly more benign, less potentially invasive treatments. So one might wonder about, for example, psychological and educational therapies, dietary supplements. There's evidence for all of these that might be important early interventions. Changing the trajectory of illness. The other thing that's important to think about is then linking research onto this refined trajectory so that we could understand what factors are actually true risk factors predicting illness onset, and what factors follow the progression of the illness, such as biomarkers, that then we could measure and incorporate into a risk prediction model. Other people, as I mentioned, have been working on this idea, the concept of staging, but coming from different approaches, which can be complementary but also cause some confusion. So there's been, this work has largely been informed conceptually from people studying young people who come symptomatically with some debilitating symptoms and are on a trajectory to possibly developing psychosis. And so there's been people generalizing a model from that literature, and I talk in this paper about some of the problems I feel that brings. So for example, the focus on young people who are clinically showing signs and symptoms of potential trajectories into psychosis is that people have been focusing rightfully on the conversion between these symptoms and first episode psychosis. The problem with that, for translating that directly to mood disorders, in my view, is that based on our evidence, we would be focusing far too downstream if we just look at conversion to first episode mania. Because what we've learned from this work is these kids develop, as I mentioned, anxiety, circadian disturbances in early childhood. Then it seems like breakdown under stress with mixed symptoms of mood and anxiety around puberty, and then start developing episodes of depression, and years later typically have an activated episode. So we would be, in my view, missing the boat. And also there's been attempts at staging, but this is already in patients who have bipolar disorder, such as Flavio Kapuscinski's group, where they look at early stage and late stage illness, but these are in patients who've already met full-blown disorder. So I talk about the various staging models that are being published and discussed out there to try and make sense of them. And there's another paper that was just published in the Canadian Journal of Psychiatry that looks more specifically at the different models and tries to mesh them into something complementary, not based on consensus, but based on evidence. So the bottom line is we could be doing already a lot more for young people at identified risk of developing serious and continuing mood disorders. Traditionally, and I can say this with some authority because I am both an adolescent psychiatrist but a mood disorder specialist, and I've always straddled both worlds between child and adult psychiatry, and typically those worlds have been separate. And in nowhere that I've certainly worked in Canada do we have an integrated program, for example, where we identify parents who have bipolar disorder, melancholic depression, and say, right, what's happening with your kids? And linking those kids up automatically to high-risk services. So that's just a practical example of what we could be doing moving forward. So thanks for your attention, and those are kind of the main points that I was trying to make, I think.
Well, that's terrific. I also would before we get into a discussion, I want to acknowledge a couple other participants who've joined. Matthew Taylor, who's at King's College London as a clinical senior lecturer in bipolar disorder, and of course Andrea Cipriani, who's associate professor at Oxford in psychiatry and the editor of Evidence-Based Mental Health, the journal that's sponsoring this. So, Anne, you brought up some.
And Scott Patton as well. I can see Scott. Scott, are you there?
Scott's there. I believe I introduced Scott, but
yes, I'm here.
Worthy of a second introduction, of course.
Yes, he has an office next to mine, so he gets my greatest condolences.
So what I would, and you bring up some interesting points, and well, a lot of interesting points, and I think one of the important things I think is several things. One is to look at your staging model itself, which I think is quite an interesting idea. The question is at each point in the way that you stage things, it seems that retrospectively it would be quite easy to figure out later who is in an early stage of mood disorder after you've already known that they've developed a mood disorder. But what sort of information do we need to have to be able to make these kind of predictions accurate going forward out of a large population?
Well, again, sorry, are you finished there, Michael, or should I?
No, you're allowed to interrupt. That's
I tend to be a little impulsive. It's just my anxious nature. Well, I think that one major shift could be the way that we conceptualize diagnostic approach in psychiatry. So if we think about our internal medicine colleagues, who I always think are kind of like the Sherlock Holmes of medicine, you know, we typically in internal medicine, we don't just go with the acute symptoms in front of us, fever, you know, abdominal pain, and say it's this. We say, okay, right, so what has been the course leading up to this acute episode? What has been the more remote course, clinical course, over this person's lifespan? And what are the other risk factors in play that are relevant? And for psychiatric disorders, this is very much an emerging field in terms of risk indicators, but what we can say is we definitely know family history is a lens through which we can make better sense out of otherwise non-specific symptoms. So, and it's not just, I think Andreasen published this years ago, if you just ask people, is there anyone in your family who has a mental illness? That's not very, that's not at the sensitivity level that you need. You actually ideally would either interview or get more information about those potentially affected family members, such as was it a chronic or an episodic illness, was there psychosis involved, and those kinds of predictive factors. We also know that Gabriel Carlson and Michael Strober years ago published an important paper that I think often gets overlooked these days in the 80s, which was showing that there are some, although the depressions are very similar between subtypes of depression, depression related to bipolar disorder in young people who go on to develop bipolar disorder is typically an abrupt onset. It has a higher risk of having psychotic features involved and so on. So there's a number of both clinical, family history, clinical course, and the other thing is paradoxical treatment response. So we know that, you know, unfortunately there was a black box warning across using antidepressants across all adolescents, even though some adolescents clearly benefit from antidepressants. But if you see a young person who's depressed who gets activated or agitated, has a paradoxical worsening on particularly higher doses of antidepressant or stimulants, that's also a risk factor unmasking a potential bipolar diathesis. So we have a number of indicators that we can use, and we're certainly in research, many of us here are involved in this research, looking at other biological and psychological indicators such as rumination, reward sensitivity, inflammatory markers that we might be able to build into this clinical model.
Can I come back in on the issue of diagnosis that you brought up?
Sure.
And I don't want to get hung up in semantics, and I might do and have to dig myself out. But when I was reading the paper, it was one of the things that struck me that there's a difference between diagnostic classifications and the process of making an assessment and a diagnosis. And actually, I also suspect that there are differences in the way in which we do that in different healthcare systems. So, for example, in the UK healthcare system, for better or for worse, we don't need to make a diagnosis or give a diagnostic label in order to give someone access to treatment. So I think we pay less attention to the technicalities of the diagnostic labels at times there. But
Yeah, I think
and the purpose of a diagnostic classifications is to separate who does from who doesn't, not to fully describe the disorder. So I think I would agree with you, but I might word it slightly differently. I don't think that the classification systems are where we're having the problems. I think it's possibly through people not applying what we all know to be as a good assessment and a full assessment, formulation, and diagnosis.
I would agree. I think the Canadian, Scott, this would be interesting to hear your perspective. The Canadian approach to diagnosis is a hybrid between the UK and the US approach. So, in other words, what I'm trying to say is in Canada, we don't need a diagnosis either. We have the equivalent of the National Health System here. It's a public system. We virtually can see patients and set up services the way we see fit. The problem is in our training, and I think that we're getting further and further away, certainly in Canada, from understanding that the DSM or ICD system was intended to be used in the context of a comprehensive psychiatric evaluation. And what's happened is people have really sort of collapsed that into a checklist approach to diagnosis. And actually, nowhere is it, that I'm aware of, is it written as the standard of practice that one in making psychiatric diagnoses should incorporate all of the indicators that I've been discussing in terms of family history, clinical course, you know, and understanding really, taking a developmental approach to psychiatric diagnoses.
Well, whilst I think that's not always what happens here, I certainly would say that's what we teach and that's what we expect. So we spend quite a lot of time recently redoing our own clinic documentation to make sure that people are doing that kind of comprehensive assessment.
Right. Well, that's great, and I think that's something that we could certainly we should certainly move back towards in psychiatry in North America. What do you think, Scott?
Yeah, I agree. Actually, I think most people would agree. You know, the DSM is not intended to be a gold standard classification system. It serves a variety of purposes, keeping statistics, for example. And you're right, those categories and those criteria shouldn't be reified excessively. This is a quick and dirty shorthand to enhance communication and reliability. It shouldn't supplant basic clinical skills.
Right. And even in the UK, do you feel that it's the case that family history is as prominent in determining what trajectories people could be on, and also even understanding possible differences in treatment response?
Well, personally, I don't think it's done well enough. I mean, I fully agree with you on that part. Argyris, from the child and adolescent perspective, would you have a thought on that?
I think certainly I would agree that a good formulation includes that, and it will inform. So, for example, in someone who presents with unipolar depression, to take a very practical example, if they had a family history of bipolar disorder, that might add a degree of hesitation in rushing with antidepressant treatment. So it certainly informs decision making, but the problem with family history is, great as it is, that in its own right, and even with other indicators, is not a very powerful predictor. Firstly, because it can be quite generic. So increased risk for bipolar can also increase the risk for all sorts of other disorders, as we know. And secondly, it's just, even for that, even for as a general indicator of mental illness, it's not particularly powerful, but it's certainly very important, and it has a great place in an algorithm, and we certainly encourage people and our trainees to look very carefully at that, and sometimes it's the strongest indicator you have of bipolar. But say if someone had a family history and softer symptoms of mania, as it were, so say episodes of short duration or something like that, and depression, it just forms a stronger impression. Now, I think it's an empirical question, though. It's something that research should take up, whether, how strong these predictions really are and how helpful they are, and the extent to which they can be counterproductive because they're being overinterpreted. So I think it's a bit of an open question, and something we need to do research on, certainly. Yeah. I don't know whether anyone has looked. To my knowledge, no one's done that. Look at the sensitivity and specificity of different algorithms in adolescence, for example, where family history of mania has been added in as a variable, and see what difference it makes to the actual prediction.
Yeah, we're
talking about a proper predictive model rather than whether it's a tiny fraction of the variance, which I know it does, but whether it's sensitivity and specificity of the positive predictive value.
Yes, and this is one of the challenges. Hopefully, fingers crossed, we get refunded, because we're between funding cycles, which is a major challenge. But what we're trying to do is actually do just that, based on all of these potential predictors, actually look at different models to see what sensitivity and specificity we get. And so that's coming. But certainly, we haven't put it all together, but we can certainly show, for example, that from these high-risk cohorts, young people, children who have clinically significant anxiety syndromes have a 2.5-fold increased risk of developing bipolar disorder. That would be true also for circadian rhythm disturbances. And these are already kids with a positive family history. So I think that's the other cautionary note I'd like to say is certainly what I'm not saying is that if you have a child with anxiety or with sleep disorder, you have to be worried about bipolar disorder. It's only in the context of kids at confirmed risk, genetic risk, familial risk.
So Anne, one of the things that you said that was interesting is that in terms of the staging model, it's thinking about interventions that are lower risk, such as psychoeducational interventions or dietary interventions. And in the United States, certainly people are apparently quick to medicate children with medications that are approved for use in adults, but aren't necessarily well studied in children. So, if we were to sort of have a predictor model, what kind of specificity and sensitivity and positive and negative predictive value would we need to have some confidence that what we are doing is going to be safe for people? And if so, how do we accomplish that? In other words, you mentioned that there are a number of groups internationally who are looking at staging models for the development of mood disorders. How do we leverage all the work that different groups are doing to accomplish this?
Right. Well, a couple of thoughts immediately come to mind. One is there is a newly launched international working group task force being supported by the International Society for Bipolar Disorders, and it's chaired by myself and Jan Scott. And we had some technological difficulties with our first conference, but we're just organizing a conference to look at exactly that question of how can we combine our cohorts to get enough power to answer some of these more complex questions. So I think that's a very positive, productive step forward. I think the other thing is as you've mentioned, there are individual initiatives, pilot studies showing that, for example, the Oxford group looked at, for example, folic acid or folate as a possible prevention treatment in kids at familial risk for bipolar disorder. And as one example, there's certainly examples from the Denver group, Colorado Micklewitz, looking at family psychotherapeutic, psychoeducational interventions and showing some positive effects. And what I'm very interested in is from my clinical observations, because I am, after all, just a simple, lowly clinician, really, who's gotten into research. But what I find fascinating is what I'm perceiving as psychological changes in young people as they're starting down the trajectory into mood disorders. So otherwise more resilient, robust young people start to have more self-doubt, more ruminative processes, I think, clinically. And it's that observation that now we're going back to systematically test, and actually with colleagues from the UK, including Richard Bentel and Stephen Jones. So I think while we're at the early stages, I think sometimes you don't need large studies to show big effects if these processes are going to be helpful in determining. And then we're also combining our resources with groups internationally to look at exactly how, what kind of sensitivity and specificity can we achieve.
And just on that point, it's good to talk about sensitivity and specificity, but we need to remember too that the predictive value of any kind of algorithm is going to depend not only on those factors, but also the base rate in the population in which the algorithm is applied. So I think you've been very clear about that, and that the estimates you're making in terms of predictive value need to be interpreted within the context of a high-risk cohort. Right. And actually, the predictive value is likely to depend very strongly on that level of risk in the at-risk cohort.
Right.
Can I just mention our experience, which was in student populations here, who we looked at from the point of view of hypomanic symptoms, very simply, and then followed them up after a couple of years. And it was very striking that although you could certainly see an increased risk in those who we classified as high risk of actually attending for care or some sort of counseling or whatever, actually the largest numbers came from the low-risk group. And this is the usual epidemiological paradox that, identifying high risk in groups where you don't really have a very predictive model actually doesn't detect all the cases, and you kind of wouldn't want to spend all your resources on the high-risk group because most of the people you see are actually, when you first see them, low risk. So I think thinking about things from a slightly more public health perspective is also challenging. I'm not sure I have an answer to this, but in thinking about the relationship with circadian dysfunction and also just looking at the way our students live their lives, some kind of lifestyle change around timekeeping and sleep, you can't help feeling might be of a general application and also potentially having a wider impact upon relatively low-risk people as well as the high-risk. So I don't know that anyone has proved that, but it seems to me worth putting into the mix alongside the high-risk studies from which I accept we can learn a great deal in terms of psychopathology and even neurobiology.
Yeah, I think. Sorry, I just want to make a comment, if I may. I think those points from Scott and from Guy are very important because we do need the epidemiological studies alongside the high-risk studies. So, there are some pretty benign, easily feasible interventions that one could and should study in young people, such as exercise, diet, sleep regulation, which might have quite a large impact. But on the other hand, also your yield for major psychiatric disorders and understanding the trajectory is going to be lower. So I think you have to have the two parallel groups to really understand specifics in terms of trajectories into psychiatric disorders as well as general public health strategies.
So if you were going to use a staging model, you would want it to be similar to the way things are staged in medical disorders, which is to say that not everybody who is at stage 1 progresses to stage 2 or 3 or 4 or so on. And so it might, I mean, Guy, does that in some ways sort of fit with what you were thinking about?
Well, I mean, it's all completely theoretical at this stage because no one's really done the work, so let's be fair. It's guesswork, but I mean, if you take the analogy from something like, you know, treating raised cholesterol, I mean, that has progressed from, you know, high-risk studies of families who have super high cholesterol and get heart attacks at 35, to treating completely normal populations with statins on the grounds that this reduces risk even in people who kind of are low risk. So I think we should be open-minded about this. I think the staging is...
So if you were going to use a staging model, you would want it to be similar to the I think that's Tony James who's going to use stage 1 echoing on us. Stage 2 or 3 or 4 or so on.
You've suddenly become two people, Michael. I know.
God,
we can't get enough of you, but there's now two of you on the line.
You're very Tony.
Yes. Well, I mean, it's all completely theoretical at this stage because so let's it's guesswork. But I mean, if you take the analogy from something like, you know, treating raised cholesterol, and that is from, you know, high-risk studies of family.
All right, so Guy.
Hello.
It was good to hear you say that twice. Well, I mean, one of the concerns over here in the United States, and and it's important to me, although I'm not a child and adolescent psychiatrist, is there's Tony James, is that we tend in the United States to medicate children, and we see medications as a solution that we intervene with early. And my sense from what what you're talking about, Guy, and what Anne is talking about is that we want to have less. We want to turn to broader-based, safer, less aggressive interventions for larger groups of children, perhaps, and not be so quick to use medications with children who have prodromal symptoms without knowing for certain that they're going to develop later a full bore form of a mood or psychotic disorder. Turns over here in the United States. And it's important to me, although I'm not a child and adolescent psychiatrist, is there's Tony James, is that Tony, I had to mute you because you keep repeating what we're saying for some reason.
I think it's a technological glitch. I think, if I may jump in there, I think it's a very, very important point, and I guess I think about a number of different things at once. One is, you know, if you talk to young people, and young people I'm meaning now adolescents, right, and young adults. We can talk about children in a minute, but they actually don't want to take medicine. We've done some studies in this. They'll say to me, you know, is there anything else I can do? Like, can I do acupuncture, yoga? Is there any, you know, can I take omega fatty acids? And by the way, I don't have my parents' illness. So there is this probably healthy resistance to not accepting the sick role, not wanting to see that trajectory, because typically, unfortunately, many of the parents who we identified, at least initially, were sent to a specialty mood disorders program because they were, quote, either refractory depression or refractory bipolar disorder. And the problem in majority of those patients was, the adult patients, the parents, was that they were either on polypharmacy, you know, so on a number of different things, which is not a benign situation, because if you have for example, a lithium responsive bipolar disorder, there's evidence that suggests, and certainly clinical experience, that if that person is given chronic sodium divalproate, like an anticonvulsant or an antipsychotic, or a chronic antidepressant, it can flatten the episodic course, and that person is rendered chronically unwell. So, you know, the kids don't necessarily want to take prescribed medication, and this is actually true in other medical dilemmas such as juvenile diabetes and asthma, we're just, as human beings, not A, good at taking medicine, and B, especially when we're younger, we don't want it. So I think in terms of acceptability, it would be wonderful to have something that was potentially not the usual prescribed medication. I think the other dilemma is, let's say you do have a lithium responsive illness, you know, you do want to have, if you can, less exposure of the kidneys to lithium over one's lifespan. So the question becomes, do we need to start something like lithium or another mood stabilizer now, or can we do something? And then when you're looking at young people, children with risk or prodromal symptoms and familial risk, of course you don't want to jump to prescribed medication, because we don't know that the brain is going through an accelerated development, and we really haven't studied things very long enough or very systematically to understand what the implications are. So I think it would be very important for us to understand what would be more acceptable, benign, and possibly very potent early interventions, such as dietary supplements, exercise, sleep regulation, psychological process work.
It's also very important to think about what is it that we're treating, and we can only treat what's in front of us. We're not, when we're talking early, and I think, Michael, you said very importantly, you know, these are often the prodromes of what will come later. It may not be a prodromal illness. We may actually have what looks like an episode of depression there. We may have a mixed depressive anxiety disorder. We may just be seeing sleep difficulties at that time. But one can only treat what one is seeing, not what one's predicting might be the case in 10 years' time. And I do think that there have been times in recent years, particularly with mood instability, that it's been too easy to label, or too quick, sorry, not too easy, too quick to label these as bipolar disorder, when that's really not what we're seeing or what we know.
Yeah, absolutely, absolutely. And I think the other thing too is that you know, that even in young people who have a bona fide recurrent mood disorder, so let's say they're, you know, having recurrent melancholic depressions that are debilitating and have a serious risk, you know, the question becomes then, how long do you continue the treatment as well, you know, and even in those kids, our experience has been that they actually respond, if they do require and accept treatment with, say, a mood stabilizer, then those young people do respond to monotherapy. We've published a paper on that. So there's this common belief, which I would call at the level of myth, because I don't think it's evidence-based, but happy to debate it, that young people have a more severe form of bipolar disorder and that they require polypharmacy. And I see these kids whacked on numbers of different medications, and you know, that's just, if somebody does require prescribed medication, we should be looking at trials of systematic monotherapy, and about 85% of young people in our experience respond to monotherapy. And then, of course, young people are a natural discontinuation model because they don't want to take medication lifelong, and none of us would. So it becomes then a question of when do you discontinue it and follow them, and how do we follow and monitor the activity of the illness.
But can I just intervene? I generally agree. I mean, there are two different things here, right? One thing is, what does one do for people who are at risk or seem to be at risk? And it may be that a broadband type of treatment, not necessarily geared towards bipolar, may be very useful. Exercise, whatever it might be, social rhythm therapy, all sorts of candidates. But the reality is that for manic symptoms and depressive symptoms, non-pharmacological treatments have been a bit of a disappointment in certainly in adolescents, and correct me if I'm wrong, but it seems to be fairly similar in adults. So even things that look promising, such as family-focused interventions for people with young people with bipolar disorder, don't seem to be working that well in the end. So the message for clinicians shouldn't be necessarily to avoid pharmacotherapy. I'm just saying this because as there are errors of omission, just over-diagnosing and over-treating, what I often also see is areas of omission, so not treating enough. And also, it's interesting what you say about how much young people want to have the treatment. Again, I don't know of good systematic studies, but drawing an analogy to ADHD, qualitative research suggests that actually young people often find treatment with medication very helpful for certain aspects of their treatment and of their life. And so I suspect, and this is an anecdote to be scrutinized properly, that there's a mixed group. It's going to be a mixed group. Some people will not want to take it, others will be very grateful to take the medication, and so will be their families. So I don't think that necessarily people don't want to have therapy. I think psychological treatments are also quite a big commitment for families and young people. If you have to be there every day, it also can cost quite a lot of money for a public health. So, you know, as I said, not largely pro-medication, but just as just to present the other side of the argument.
Yeah, no, I think that's important, and I certainly think I've had clinically that experience too, where young people, interestingly, have no problem or I shouldn't say no problem, but are much more open to stimulants than they are to mood stabilizers. But I think that certainly, I think that's right. I think, in summary, we want to be able to have potent, proven, effective, acceptable interventions with a favorable benefit-to-risk ratio early on, which you know, do no harm. But if somebody is seriously ill, then obviously we shouldn't hesitate to intervene with what would be proven effective medication. It's in the population, the at-risk for mood disorders population, in my experience, people aren't keen on continuing medication lifelong or long-term. So that becomes a challenge in terms of when to stop and how to monitor.
Just as a process point, we're over time, but we started a bit late. If people are willing to stay on for 5 more minutes,
sure,
we can continue for that long. So I wanted to go back to the point about thinking about how we're going to get enough data so this moves from something that's theoretical, as Guy pointed out, to something that is something that can be used more practically. I mean, one of my interests is in trying to break down barriers between groups so that we can share data in a larger way. Mm-hmm. It's not just that I'm in the at the home of big data here at Stanford and Palo Alto in Silicon Valley, but is there a way that we can reconceptualize how we're collecting information and doing studies so that we can include more data in a primary way, not necessarily in a way that requires us to do meta-analyses? Guy, do you have thoughts about that?
Well, I think the most promising direction, it seems to me, is to try and supplement the clinical assessments that we routinely make, well, to improve them, which is, you know, something we've tried to do with this system, True Colors, by having self-ratings on a regular basis, but also to try and add to that more objective measures of particularly movement, but anything else that is informative. And I think the advantage around that may be, and this is very, very preliminary, but our impression is that energy and movement are really quite sensitive and important variables in young people with bipolar disorder. Well, in fact, even with older people with bipolar disorder. And they're not that difficult to measure. And in terms of thinking about how you monitor and give people useful feedback, and given that, you know, the health obsessions of the people who live around you, Michael, I know not you personally, I wouldn't include you in this, but, you know, the people in Silicon Valley are looking to make even more money out of providing middle-class obsessionals with information about their bodies, the temples that they're running around in. And I think that may, in fact, be fantastically useful to us, because I think it will give us devices that will collect information about activity, which could be fantastically useful. And I think it may actually turn out to personalize medicine for us in a way that I couldn't have imagined 10 years ago, because you know, it may be that individuals have quite an important and individual relationship between how they move around and the amount they move around and their mood or their level of energy or whatever. And that becoming more aware of that, being more conscious of it, may actually be a very important element in self-management, whether they kind of know they've got an illness, whether they've got an illness, or whether they're prodromal or whatever. Right. And I think the opportunities are really, really very interesting in that area. And it's the personal nature of the measurements which seem to me particularly promising. And it obviously moves us beyond diagnosis, and it moves us beyond a lot of the things that currently are a barrier. So I'm pretty optimistic about that. But clearly, again, it's very, very theoretical. But it seems to me that for once we seem to be moving in the direction that the patient, the consumer, may want to go in. You know, they really want to wear an Apple Watch and to monitor themselves till they fall down.
There's a lovely program called the Ginsberg program, which was set up by the NHS in Scotland to look at depression. It's also still in its infancy, but it's an online information gathering tool that people with depression can sign up to. The only requirement on them is to answer 3 questions. They actually answer 3 questions every day through a smartphone. But the nice thing about it, and it actually seems to really work, is that they can link a whole range of other apps. So actually all of the wearable technology can immediately upload and then cross-reference the data. So we're exploring that actually in the ADHD field. It's actually very similar to what you're talking about, Guy, but what we were very impressed with was the way that Ginsberg had done it seemed to draw people in. And I guess if you can draw people in with depression, to actually be answering questions every day and allowing that information to be gathered, you're doing something right.
One of the things about those kind of data are that they are both objective and passively collected in a lot of ways, and that's one of the most important things, isn't it? That we don't have to. There probably will be a point where the devices that people carry are going to be collecting passive information about them that will help us accomplish those goals. And those data are objective, aren't they? They're not, they don't require somebody to make a judgment themselves about how they're feeling or acting, but rather they're actual data collected about their behavior.
Right. Yeah. Absolutely.
Yeah. And one of the challenges, I think, is how to analyze this data and how to use the outcome from this big data analysis, because it's not easy.
Well, and
I think the other thing, Guy and Andrea and Tony, is the work that's been going on in Alzheimer's that's now moved to Oxford with Simon Lovestone, and actually that kind of deep text mining and being able to get inside electronic health records, so that the onus moves away from asking clinicians always to fill in X, Y, or Z scale, to actually pulling out the information that's in there. And I think there's a lot to look forward to in that.
Yeah, it's very interesting. I don't know whether it tells us that the scales were really pretty much of a waste of time to start with. That's the slight worry I have, in that you seem to be able to deduce everything from simply picking out keywords from the mass of nonsense that's in the notes. It's very extraordinary. I mean, you're absolutely right to highlight it, but the message for me is I'm not quite sure what direction it goes in. The other thing that they are interested in, of course, is movement as a measure of in dementia as well, and that of course is, you know, along with ADHD, along with bipolar disorder, dementia and movement are also going to be highly informative in different ways. And I think the future's, I mean, you know, we've got to wind this up in a minute, but I think the future is very bright for this kind of approach, and it takes us well beyond arguing about whether DSM-5 is quite right or quite wrong, or, you know, all that stuff that is so uninteresting. So, you know, I think it's a good time.
I think, too, just if I may add, just going back to mood disorders and bipolar disorder in particular, it's the energetic shifts, and the variability and the sort of dysregulation that I hope that we'll be able to capture with these more
appealing to young people and sophisticated, sort of highly refined data collection. I think it's going to be appealing to young people. I think it's going to be very informative. As Andrea says, it's going to be a bioinformatic challenge. But I think that's going to help us pair together with colleagues from mathematics. So I think, I think it's very exciting as well.
Yeah, and then, sorry, Scott, go on.
No, I was just going to, no, Andrea, make your last point, because I think I would feel responsible.
No, I think it's also interesting, the ethical point of view. Here in Oxford, they are discussing a lot about the ethics around big data, which is not granted at all. So in the future, a lot of problems will come out, and we need to face them and think about them probably in advance.
Very much so. Very much so. Well, I would like to say it's interesting that this discussion, which is on a Google Hangout, ended up being about big data, which is what Google is built on. So on that note, we will have to end. I want to thank Anne Duffy, especially for presenting her paper.
Thank you for the opportunity, and thank you for your interest.
And everyone else here, Scott Patton also from Calgary, David Coghill from Dundee, Matthew Taylor. Matthew, we didn't hear from you, but that's okay. Argyris Stringaris from London, Guy Goodwin, Tony James, and Andrea Cipriani. So thank you. I look forward to inviting people to another one of these Hangouts, and I'm glad that you were all willing to be part of this bit of an experiment that we're doing for evidence-based mental health. So thank you. Enjoy the rest of your day and your weekends.
Great weekend.
Thank you.
Thank you.
Bye. Thank you.
Bye-bye.
Thank you, Anne. Bye.
Bye.
Thank you.
Thanks, Anne.